Thank you very much, Elaine, Claudio. So this will be a slightly different talk from the ones you've heard. What I'm trying to do is to cast the net a bit further forward, 5 years or so, and see what therapies we might be using in the ICU, not so much the process of management as we have now. So it consists of two things. One is which targets and which patients, and the matching of patients to targets is absolutely critical, the precision medicine story. But I've addressed which patients in several previous talks, and prevent me and the rest of the audience from getting bored, I'm not going to address that some more. As far as which targets are concerned, well, the first set of targets is those that we're using now, but we'll shift from responding to physiology to modulating underlying biology. What do I mean by this? So the current management of intracranial pressure with brain tissue oxygen monitoring is probably best summarized using the CIVIC guidelines that are here. But the problem with this is that it primarily uses interventions that respond to a rise in ICP with variable effects on control, but does not affect the underlying mechanisms. What we would like to do is to prevent the biology that leads to these things. And there's increasing interest in developing drugs that prevent or reverse the molecular mechanisms that lead to ICP rise. And there are three classes or three drugs that are currently under trial and worth talking about. The first is using glibenclamide at the sulfonylurea receptor. The combination of the SIR1 receptor and the TRPM4 channel is an integral part of contusion expansion and pericontusional edema. And Biogen are conducting a phase 2 trial looking at the effect of this. This is dependent very heavily on some outstanding work done by Mark Simard and Ruchi Jha, the first and last authors on this review article. The second is looking at neurogenic inflammation driven by substance P and the NK1 receptor. And this is work that has emerged from Australia from Bob Wink's lab, being run by Procura Neuro. And this is also in phase 2 trials and would use inhibition of neurogenic inflammation to reduce ICP by preventing edema. And finally, Menon, who is primarily a food company, they advertise themselves as from field to fork, but have a compound called anti-secretory factor, which is salovum, which is actually currently marketed as a food supplement. And they are running, there's this protocol for a food supplement trial, but they're also going to do a formal phase 2 trial. And both of those, I think, would be interesting in terms of the results they produce. So watch out for these three compounds and similar classes of compounds. The second thing that we will probably see a lot of, and this has been given an impetus by COVID, is modulation of the innate and adaptive host response at early and late time points. So there are a whole host of drugs that are being used or have been used either in TBI or in other conditions which are candidates here. There are cytokine and other mediator antagonists, inflammasome inhibitors, statins, minocycline, histone deacetylase inhibitors to look at epigenetic modulation, nanoparticles, and then a whole range of drugs that have been used really as immunomodulators in neuroimmune disease. And it's useful to classify these. Those that are in green are in trial in TBI. There are others that have been used in TBI routinely. So both melatonin and propofol and valproate are used conventionally in our patients every time. But both melatonin and propofol have a role in inhibiting the inflammasome, and valproate is a histone deacetylase inhibitor, so may be able to modulate epigenetic changes. The ones that are in the sort of orangey color are drugs that are used in other indications. And the great advantage is that their safety is well recognized. We know what they can and can't do, but their application to TBI in terms of repurposed drugs may be something to look forward to. So the question that when I talk about this, people come and say is, but we've tried inhibiting inflammation before and it hasn't worked. Why should it work now? And this is the CRASH trial, final results showing that not only did it not work, it caused harm when used in high dose. The point is that this was a pragmatic trial. Its great achievement was organizational, but it was rather naive in its terms of its biology, using industrial doses of steroids with no attention to blood sugar, no attention to adrenal suppression as a consequence later on, no attention to the increased risks of infection, is not an approach that you and I would have in our intensive care units. There's no requirement to give these people a PPI or a H2 blocker. And finally, we also have currently better understanding of the pathophysiology and side effects, and blood, biofluid, and imaging biomarkers, and we can use precision medicine approaches to match patients directly. So as an example, this was a phase 2 trial that was conducted from Cambridge by Adele Helmy. We've known for some time what the profile of cytokines is. Microdialysis catheters go in to measure lactate pyruvate ratio as part of clinical care, but by using 100 kilodalton cutoff catheters, we also get access to biomolecules. And we know the various mediators and what time points after the injury they emerge, and that provides a rational basis for using a drug, in this case, anakinra IL-1RA. And we can, first of all, make sure that the drug gets into the brain. And you can see the blue bars are the endogenous IL-1RA and the red bars are the treated patients. There's a lot of variation between subjects, but you can actually demonstrate that the drug gets into the brain. You can then see what effect it has on the overall cytokine pattern by undertaking a principal component analysis. You can isolate which cytokines are being affected. And then you can ask whether this has an effect on lesion expansion, here using MRI and showing that lesion expansion it has this particular time profile. And we can ask the question whether these drugs, all of the anti-inflammatory drugs I talked about, make a difference, or more directly look at neuroinflammation using PK-1295 PET. Now, this is not going to be part of our clinical care paradigm, but what it will do is allow us to select drugs for big phase 3 trials that are much more likely to succeed. And I think that pathway is something that we will explore. So much for things that you put in via an injection, but you can also put in cell therapies. And here, there are a whole host of things that are emerging. There are issues regarding what mechanisms, whether there's a common effect, whether it's modulation of neuroinflammation and microglial phenotype, or do they actually engraft and replace the dead cells? Do they produce neurotrophins locally? Is there modulation of systemic inflammation, whether you use autogenic or allogeneic cells with or without modifications? Most of the clinical studies so far, and I'll describe that in just a minute, have used either allogeneic umbilical cord mesenchymal stem cells or bone marrow-derived autologous cells. But there's also interest experimentally at this stage in using embryonal stem cell-derived cells, and also the products of cells, so exosomes and cell-derived proteins. So Mike Chop's lab in the States has done an awful lot of work looking at exosomes, and I think we should watch that space. So what's happened clinically? Well, the studies that have happened so far, there are 6 studies in the acute or subacute phase, which have included 135 patients in open label, but also 1 RCT of 15 actively treated patients and 5 controls. There's also been quite a lot of studies in the chronic stage, weeks to months after injury, and these are have included 64 open label patients and 101 patients in RCTs, 66 of whom have been treated with active treatment. And they've used a mix of autologous bone marrow-derived stem cells and umbilical cord mesenchymal stem cells. These have generally been shown to be safe. There may be a possible signal of efficacy. The Fugl-Meyer scale is a motor scale looking at limb recovery, but also Glasgow Coma scale in the most severely injured patients. And that may be a population, the patients who don't wake up and have very little to lose, maybe a population where we'll use this perhaps earlier than otherwise. But there's difficulty disentangling the natural recovery from the treatment effects, but there's more sophistication there. I'll just make the point there are also attempts to increase endogenous mechanisms for repair, and many of these stem cells that you see, endogenous stem cells, come from the hippocampus or the subventricular zone, but there are also astrocytes which can actually regress to form stem cells, and ways to actually cause endogenous stem cell production may actually facilitate repair. This seems a bit like science fiction, but I'd refer you to these 2 papers. The first is a paper which essentially covers this, and then the slice, more perspective article says who, when, where, and how we would use stem cell therapies in TBI. And indeed, there is a study that's going to start, run by Giuseppe Citerio and Elisa Zania. Giuseppe is from Monza, and many of you will know him as the editor-in-chief of ISICEM, and Elisa works at the Mario Negri Institute. There's been data suggesting that mesenchymal stem cells are helpful in neurological injury, and then they've been used in other conditions as well, these brown boxes down there. The first experiment at the Mario Negri Institute was a long time ago, 15 years ago now, but now they have funding from local funders to undertake the MATRIX study. The primary outcome is safety of mesenchymal stem cells administered IV within 48 hours of TBI at dosage of 80 or 160 million cells. And second, to see whether there's a change in biomarkers. You remember I told you we have better biomarkers, and here NFL has been chosen. So this is a concrete study. This is something that is coming to an intensive care unit within the next 12 months, and many more of these will be coming to your ICUs with the prospect for repair. The other thing that's emerging now is the realization that you can get quite early neurodegeneration, which carries on to weeks and months after TBI. So here are data from our group showing that if you compare 6 months after TBI to maybe 5 years to 10 years after TBI, there's volume loss in the brain. The brain looks older and continues to age in an accelerated fashion. What are the underlying mechanisms? So this is, again, a PET study from our group in TBI with patients within 48 hours of TBI and then going all the way up to 1 year. So this is not new. We have known for a long time that traumatic brain injury results in amyloid deposition in the brain in terms of plaques, exactly the same chemistry that you see in Alzheimer's disease, probably because the axons are torn, amyloid precursor protein is spat out, the secretases work on it and produces too much amyloid. And because it can't be cleared by neprilysin, that gets overwhelmed, they form plaques, and they have acute effects. They're neurotoxic, they change vasoregulation. And you can see that they're there within a day or two in young people after TBI. So interventions to try and address this may be useful. Similarly, we know that inflammation is there acutely. I showed you the PK1295 image of the acute phase. This is work from Imperial College, Dave Sharp's group, showing that it persists up to 17 years afterwards. And modulating inflammation in the early stage may prevent late inflammation. So this is a target that keeps on giving over time. And also tau deposition can also happen and can carry on for long periods afterwards. The problem, of course, is this. Not all patients with TBI show evidence of neurodegenerative pathology, and I've shown you advanced MR and PET techniques, but these are expensive and logistically unfeasible. But there are blood biomarkers that are emerging based on phosphorylated tau. For example, we've shown that p-tau181 is elevated at late points in a subset of patients, and amyloid A-beta 40-42 ratios. And conventional biomarkers such as NFL are persistently elevated at 6 months, and they predict subsequent volume loss. So why is this important for me as an intensivist? Because that is a process that's initiated while the patient is in my ICU. And there are things that I can do to prevent that progressive inflammatory insult from progressing. And once we find that these things are important, there are a whole host of drugs which we don't have to actually devise because the dementia field has got tens, hundreds of drugs that are coming, many of which are disease-modifying drugs. Here in this analysis, the green chunk here is all disease-modifying, which includes anti-tau, anti-amyloid, and anti-inflammatory therapies. And these are drugs that we can take to our practice. We have to be a bit careful. For example, lecanemab and aducanumab, those are the two new monoclonal antibodies that have been shown to clear amyloid, but they have a small incidence of ARIA. This is local edema and hemorrhage associated with clearance of the amyloid. And in someone who has a tight head, having that would not be a good idea. But there'll be other compounds that come along which have fewer risks, and we really need to think about those. And finally, we'll need to think about arousal therapies and poor outcome. In the other talk I gave earlier in this lecture theater, what I showed was this paper of now 10 years ago from Joe Giacino showing that amantadine, because of its presynaptic and postsynaptic dopamine agonist properties, can accelerate arousal. We don't know whether it eventually increases the number of people who are recovering from coma, but it can accelerate recovery from coma. But there's a whole host of other drugs and interventions, transcranial direct current stimulation, depth electrodes, a whole host of other interventions pharmacologically that can be used. And I would encourage you to read this nice review from Brian Edlow and colleagues, which cover some of those. So just to summarize, there are a lot of new interventions that are coming your way, and you may choose to use in your intensive care units in the TBI patients over the next 5 to 10 years. And we also have, as has been covered in previous talks in this conference, ability to identify patients who would be most suitable for these drugs based either on the severity and prognostication or selecting endotypes based on their biology in that individual. And this, I think, is a combination that is more likely to succeed than our approach of using very non-specific drugs very widely across the patient population. And we should watch the space. Thank you.